Good morning, everyone. So I'm going to really follow up on Dr. Vargas's talk and really obviously focus on the disease that we all treat and understand, and that's prostate cancer. And really talk a little bit. I'm a medical oncologist, been seeing prostate cancer patients for the last 20 plus years, and this is a very exciting time. We're going to talk a little bit more about how PSMA diagnostics is completely changing the field from the early diagnosis of newly diagnosed, even localized prostate cancer. It's completely changed my practice there. But I'm going to focus right now on Lu-177 PSMA therapy. And part of this is about the landscape. You've seen slides like this. And basically, it really hasn't changed. I think, obviously patients are, how you define localized, the so-called rising PSA state is actually in quotes, because soon we'll be able to see where that cancer is coming from. The patient knows that he has relapsed because his PSA is rising and we couldn't tell where it is. I think that's going to become a diminishing source. But it's really this final common pathway at the opposite end, this metastatic CRPC state where patients are dying. And that is where I think we're focusing new therapies. And this landscape, of course, you see in pink the ARPIs, you see radium, chemotherapy used in different settings, Smilow T still on the list. And then you see that PARP inhibitors and immunotherapy are still an available option for advanced patients for a small percentage. In the case of IOs, it's only 3%. We have a session on immunotherapy that we'll go over that in. And PARP inhibitors maybe about a quarter. But Lu-177 PSMA-directed therapy is obviously really, really critical and one that I think we're all understanding is keeping these patients alive longer and actually improving their lives. So as you already heard, really Lu-177 is a beta particle that is attached to a PSMA ligand or antibody. There are people using different ways of attaching this to the prostate cancer cell. The vast majority of advanced prostate cancers express PSMA on their cell surface, so it's a very good target. Will every cancer have a target like PSMA? It's not clear. This is an interesting part of our discussion about whether this principle will work across all types of cancers, but PSMA happens to be a really good target in prostate cancer. So who are candidates for PSMA radioligand therapy? That's what RLT stands for. And again, what you see here, if you look on the left side, is the disease state starts with the most advanced and is moving earlier and earlier. So I'll talk a little at the end about the fact that there are some clinical trials going on, not just in the hormone sensitive, but even in the localized high-risk disease setting. And of course, because of the toxicities, which we'll talk a little bit more about, including you need to have a patient who's a candidate, adequate bone marrow function, kidney function, liver function, because that's some of the toxicities we'll be talking about. But interestingly, again, even though the vast majority of prostate cancers express PSMA, if you don't actually have PSMA expressed on your particular cancer, then this drug shouldn't work, right? So this is an example of this kind of, an old but new concept, which is that the treatment works if the tumor expresses the marker on its surface. And I'm going to talk a little bit more about these three trials, but what I highlighted in yellow are the kind of the first three trials, including the registrational trial Vision, which I'll go over, that defined candidates for a PSMA ligand therapy. The LU PSMA study from Peter Mack, a small study, suggested that the SUV max had to be over 1.5, and they do something different than what we do in America. In Australia, everyone gets a PSMA and an FDG PET, to the point that Dr. Vargas showed earlier. There is this discordance, and the general belief is that if you have a high FDG avid tumor, that you will not benefit from this treatment. So I'll show you some examples of that. The larger follow-up, the therapy study, which was a randomized study that compared PSMA-directed Lu-177 compared to chemotherapy. Again, you see the criteria here. Again, they excluded patients with FDG discordant disease, and they had to have SUV maxes of at least 20 at one side or 10 in the measurable disease side. And of course, those types of criteria are hard to do in the real world. So in the Vision study, all that was required was that you had to have one PSMA avid lesion, and no FDG was done in that study. So we'll talk a little bit more about what these things might mean. So here's the Peter Mack, the first study, the LU-PSMA study. And of course, something that people don't understand, and I actually don't fully understand it, the Germans were the first to do this, and they were doing it for years. And I had patients who would say, I'm going to fly to Germany and get this treatment. What I don't understand is why somehow this compound really made it to Australia. But to give them credit, the Australians basically did the trials, rather than small case reports out of a single hospital in Germany. So this was the first study, and of course it got everyone's attention. And look how late this was. This is 2018, the LU-PSMA study. But these are fairly heavily pretreated patients, and again, because they select for these patients, you see that the vast majority of patients on this waterfall plot respond. And we do see these kinds of responses. So I'm just going to show you, this is a published exceptional responder, and you can see on the left his PSA is 880. He has a floridly positive gallium PSMA scan. As Dr. Vargas pointed out, Lu-177, after you inject it, you can actually image them, and a day after the injection, you can see that it targets the tumor in a very effective way. And then within 1 month and 3 months, the guy's PSA goes down to 93 and then 30, and you can see the PET scan shows significant response. And this is not just a case report anymore. We're seeing this all the time in practice, of course. So are there poor candidates for PSMA radioligand therapies? And these are some examples of those that are. Now, this is very dependent on the idea that you have paired PSMA and FDG PETs, which we're not necessarily doing in our practices for a lot of reasons. We can talk a little bit about that, including the insurance issues related to this and whether it really is necessary in all of our patients. But here's an example of a patient with very low PSMA avidity. It won't work if you don't have the target. And these are two examples of discordant PSMA and FDG avidities in bone and in soft tissue. So you can see that if you look at these images here, you see much more uptake in the FDG than in PSMA in bone, and here the liver is full of tumor. So these are patients who are not going to benefit from Lu-177 PSMA. So the second trial that was presented at ASCO and subsequently published in Lancet from the Australians was the therapy trial. And this was a randomized study of Lu-177 PSMA 617, that's the ligand, compared to chemotherapy cabazitaxel. And these are patients who had all received docetaxel and were progressing. And you can see I talked about the PSMA imaging requirements earlier. And again, one of the important things, at least to understand about why some of the earlier studies had better outcomes, was that in the Australian study, in this study, almost 30% of the patients were excluded because they had, this kind of discordant FDG PSMA type of avidity where they had a lot of FDG positive tumor that was not PSMA positive. So they excluded these patients, and these are the 200 patients who were eligible. And of those patients, you can see that here's on the left, you see chemotherapy. This is second line post-docetaxel. And you see that chemotherapy has a good response rate, 37%, but Lu-177 had 66% response rate, double the PSA response rate. And if you look at progression-free survival, superior, hazard ratio of 0.63, and with a p-value very significant. So of course, I'm a doctor who gives chemotherapy. My patients, I was around when chemotherapy was first available. It was the first drug that improved survival in CRPC. So it's an important treatment, docetaxel and cabazitaxel. However, it has side effects. It doesn't work for everyone. And this is not about excluding drugs. It's about picking the right one in the right order for your patients. So this I think, really was a compelling prelude to the VISION trial, which was published in 2021 and in the New England Journal. And just a few elements about PSMA, the VISION trial, and I commented on this. All you needed was at least one positive, PSMA positive metastatic lesion with gallium uptake greater than the liver, and you could not, on the CT component, you could not have large soft tissue or lymph node or solid organ components that were PSMA negative. So they didn't do the FDG, but they were excluding people based on the CT if you had a large, big tumor that did not light up. So there was a little bit of exclusion of patients who were PSMA negative. And this is the randomization. It was 2-to-1 to Lu-177 PSMA versus standard of care alone. Standard of care included treatments like ARPI therapy, androgen receptor pathway inhibitors, but not chemotherapy. And the primary endpoint was overall survival and RPFS. So it was a dual primary endpoint. Here's the first primary endpoint, RPFS, and you can see dramatically improved with the PSMA targeted arm. Hazard ratio 0.40 and a median difference that was quite significant, which you can see on this curve. And OS was also positive. So again, this is a pretty late stage population, but you can see a hazard ratio of 0.62. That's almost a 40% improvement in overall survival. You know, people sometimes look at these medians and they say, well, it's only 4 months. But you have to understand that your medians really reflect the fact that some patients get really much more dramatic benefit than others. And these are very late stage patients. They're living longer. And you know, I'm not going to show all of the data, but these patients do better by many other factors, including quality of life. So this is their measurable disease response, and you can see that if you look at PR or CR, dramatic in the Lu-177 arms compared to standard of care alone. Remember, they don't really have other good standard of care options. And this is their PSA response, 7% versus 46% if you use a PSA decline of at least 50%. Now, what about toxicity? If you look at treatment emergent adverse effects, there really were no significant concerning safety signals. So I'll point out fatigue is, if you look at grade 3 to 5, a little bit more with Lu-177. Bone marrow suppression, particularly anemia, you do see a little bit more anemia here. It's a little bit of thrombocytopenia, but not tremendous. Dry mouth, as you saw from the parotid gland pictures that Dr. Vargas showed, PSMA is expressed in the salivary glands, so you do see patients with dry mouth. And sometimes it can be significant. They can have real dental issues, so it's something that you have to pay attention to. It's a negative quality of life effect. There are some renal effects that are later stage. We're seeing some patients whose creatinines go up and have some trouble with regard to renal toxicity. But because the patients get an infusion every 6 weeks for a total of 6 treatments, for the most part, we haven't seen a lot of renal insufficiency. So this is the basic conclusions from the ASCO presentation. It is clearly a new standard of care. Post-docetaxel chemotherapy, it extends overall survival, it delays RPFS, was generally well tolerated, and has become a standard in many of our practices. So we are seeing more data moving this earlier. So I'm not going to show you that graph again, but of course, what we do in oncology is we start with the latest patients and we start to move it up earlier. Why? Because those are the patients who are most needing new therapies, but also because it's the safest place to test new types of approaches. We have a lot of life-prolonging therapies, including certainly docetaxel. But PSMA-4 looked at the same drug versus a change in ARPI treatment. So this is controversial, the concept of going from, let's say, abiraterone to enzalutamide or vice versa. This is pre-docetaxel, and basically the idea here is that these patients were really not interested in chemotherapy or could use it as a post-treatment option. And you can see that's why the primary endpoint is RPFS and not OS. And the RPFS was strongly positive in favor of Lu-177, and you can see it was 12 months versus 6 months, so double RPFS rate in the group that received Lu-177 versus switching to another ARPI. And you can see that in this this graph here, you can see that all the subsets of patients really benefited from it. There really wasn't any group that specifically did not benefit from Lu-177. But this is the controversial part. You know, can you measure OS? Remember, this was not a primary endpoint, it was a secondary endpoint. But part of the problem here in looking at OS is that the vast majority of patients, depending on how you measure it, either 57% or even 77% of all eligible patients crossed over to the Lu-177 arm. So if you cross over, that's really an early versus late Lu-177 study rather than a Lu-177 versus no Lu-177 study. And you can see there's really no space between these lines. The hazard ratio is 0.98. This is why we're not so far yet able to give this to our patients pre-chemo. And we can talk a little bit about it in the Q&A, but I have patients who want this treatment, but we can't give it to them yet because if they haven't received chemotherapy of any sort, we have to give them chemotherapy first. So we've given some patients chemotherapy just to make them eligible for Lu-177. But this is a debate. There are some people who say early versus late Lu-177 should lead to an OS benefit because if it's really a very good drug, giving it earlier should improve overall survival. So we can talk a little bit more about this. There was a second study presented at ESMO called SPLASH, which used a different drug, Lu-177 PNT2002. And you can see here, it's a very similar compound, but slightly different, made by a different manufacturer. A similar study, a 2-to-1 randomization with the alternate ARPI as the randomization. And again, these are pre-chemo patients. You could have had chemo in the past for hormone-sensitive prostate cancer at least a year earlier. And you can see the multiple endpoints, including rPFS and OS. So this was presented at ESMO by Oliver Sartor. And you can see a few things. One is the rPFS does seem to be a little bit less dramatic, but was positive. This probably is related to a dosing issue, and we can talk a little bit about whether the dose was the best dose in this setting, but I'll show you some of the safety data. But again, you see the same issue here, high crossover rate, no difference in interim overall survival. There were secondary endpoints presented at the meeting in September. You can see that health-related quality of life was better in the group that got PNT2002. Time to opioid use was also better. And actually what's interesting here is that if you look at the serious treatment-related adverse effects, they're actually less in the PNT2002 arm than in the alternate ARPI arm, which suggests that this dose was certainly well tolerated, shows activity. I'd say the lack of OS benefit remains unsurprising given the high crossover rate. And there is clinical value beyond OS that's measurable, things like health-related quality of life. And then the other question is, what is the right dose for all of these drugs, right? In drugs like chemotherapy, we've learned over the years how to modulate the dose for each of our patients. If I see a really old and frail guy, I'm not going to give him full dose docetaxel chemotherapy. Can we do some of the same things here? Well, I'm not the person giving this treatment. It's our nuclear medicine colleagues. But is there an argument to kind of think of the right dose, for the right patient at the right time? And as of now, that's not how these drugs are dosed. But here's a study that used a lower activity dosing of the beta particle and showed a pretty favorable safety profile. At ESMO this year also, there was another interesting study from the Australians called Upfront PSMA. So now you can see we're kind of moving it earlier and earlier and earlier. So this is hormone-sensitive, newly diagnosed metastatic prostate cancer. And their PSAs had to be measurable, and they had all of the usual Australian approach with both FDG and PSMA. And what they did was, instead of giving them the standard of care, which was ADT plus or minus chemotherapy, they also gave them 2 cycles of Lu-177 PSMA upfront at the time of hormone-sensitive diagnosis. And their primary endpoint was undetectable PSA at 48 weeks. So the question was, is giving 2 cycles of Lu-177 in a newly diagnosed patient with metastatic prostate cancer, who's going to get ADT, who's going to get chemotherapy, is giving them these 2 extra cycles, 2 doses before they get chemo, better than just getting chemo alone, because they all got chemo. And you can see here their PSA at week 48. Remember, they're done with everything by week 48. This is almost a year later. It was 41% versus 16%, significantly better. An overall risk of almost 4-fold higher rate of achieving an undetectable PSA. If you look at radiographic PFS, you can see that it starts to split out here after about 24 months. But the hazard ratio overall was 0.58, but not statistically significant. A small study, and OS really, again, trending, but not significant. So what's the effect of this? Well, there is a study called PSMA addition that is giving 6 doses of Lu-177 to patients with metastatic prostate cancer, mHSPC. So one interesting question is worth discussing is, do you need 6 cycles? right? Like if your PSMA target starts to go away with ADT or with an ARPI or with chemotherapy, are you giving, Lu-177 to a person whose cancer is remitted enough that the fifth or sixth cycle doesn't really make a difference? This gets to another thing we are seeing in CRPC, which is, I have had patients who have CRPC, they've had a really nice response. If their PSA goes to 0 after 4 or 5 cycles, do you give them the 6th cycle? If their creatinine's starting to go up or they're starting to get a dry mouth. So I think the question here, though, is if the target goes away in HSPC because of the drugs you're giving, do you keep giving a total of 6? Because remember, they only gave 2 cycles here as a strategy to kind of get the dose in before the PSMA target goes away. And then for this, for this urological audience, the urologists in the room, there's also interest in moving this even earlier. And what's interesting to me about PSMA imaging is I'm doing them in a lot of patients with localized prostate cancer. I'm seeing some very interesting things with high SUVs, and we certainly are doing them mostly to see if they have metastatic disease, but what's happening in the prostate is worth talking about because even in patients now with active surveillance, we're seeing these changes in PSMA in the prostate that I'm not sure what they mean. And I know there are studies looking at this, but to the extent that patients ask me, do I need to have local therapy? Can a Lu-177 treatment get rid of the cancer in my prostate with in a high-risk patient without having to do surgery or radiation? This study's not going to answer that question, but it's good looking towards that future. So patients are receiving either 1 or 2 cycles of Lu-177 followed by prostatectomy and pelvic lymph node dissection, really to ask that question, can we actually use these radiopharmaceuticals, these theranostics in patients with high-risk localized prostate cancer? So you already heard there's a lot of clinical trials. I'm obviously not going to go over this, but you see they start in the advanced stage, they move earlier, first line and HSPC, and then now localized. Okay, so I showed this to you. I think it's an exciting space, a lot going on. PET imaging, I think, is the most interesting thing that's happened, and PET imaging tied to our radioligand therapies is the key. But I think PET imaging has greater value, even above and beyond Lu-177. Vision showed that this is an excellent treatment. Lu-177 is an excellent treatment post-chemotherapy. PSMA4 and SPLASH, I think, suggests that there's activity pre-chemotherapy, but it's not yet approved. Maybe we'll hear about these drugs being approved in the next year or so, but they're not yet approved. And I think that we're going to hear more about, particularly I think in the MHSPC stage, I think the upfront PSMA study gives some hint that this approach probably will work. I think the question is it worth the risk? How many cycles do we give? All of the things that we still have to learn about. And then, as we heard a little bit about alpha particles, other types of approaches, antibodies versus small molecules, this is going to change the landscape for our patients. People are looking at it in many other disease areas as well. So I'll pause there. Thank you very much.